Jake Nichols is a pharmacist like me. My name is Scott Stolte. I'm the Dean of the Pharmacy School at Wilkes. Jake is also a pharmacist, graduate of Massachusetts College of Pharmacy. He's in long-term recovery with extensive experience in community practice, academia, primary care, managed care, and pharmaceutical industry. He specializes in the treatment of substance use disorders with a focus on medication-assisted treatment. Through his 15-year struggle with substance abuse, he found his calling in the field and has dedicated his career to helping patients and their families suffering from this debilitating chronic disease. By providing clinical support for clinicians treating patients with substance use disorder and serving as an advocate for treatment, Jake has established himself as a key resource within the field. Dr. Nichols has spoken at well over 100 pharmacy, nursing, and medical schools across the country in the past 5 years, sharing his story with students and faculty, and he regularly facilitates patient and parent support groups. He has recently established his own clinical consulting group called Strategic Recovery Resources, of which he is owner and CEO. And I believe that has to do with an app or an app-based system.
That's, yes, something else I'm working with. Yes,
yeah, very good,
which I'll
very
explain.
good. Jake is also co-founder of the Research Recovery Network, a nonprofit research firm and outpatient treatment facility based in Boynton Beach, Florida. He received his Doctor of Pharmacy degree from Massachusetts College of Pharmacy in 2000 and his MBA from UMass Boston in 2007. It's a real pleasure for us to have Jake to finish up the program and be the closing speaker to tie a bow on everything. Please join me in welcoming Jake.
Well, thank you very much. Everybody hear me okay in the back? Yes? Well, good afternoon. Thank you very much for staying. How was lunch with Dwight Gooden? I couldn't make it because it was on a plane. It killed me, and I wanted to get my Dwight Gooden rookie card autographed, but I moved, and my stuff is all in piles. I have not a clue where it is anyway, so. But unfortunately, I missed him. I heard he was great. He's got an amazing story, as you all heard. So I am the owner and chief executive officer of a one-person company called Strategic Recovery Resources, okay? I formed this group because I do a lot of educational initiatives, and basically for tax purposes, it's easier to kind of separate that stuff out. So I don't want you to think I have some big corporate giant thing. This is just my consulting group. What I do for my day job, I guess, is I work for a company called Pear Therapeutics, which has a digital therapy for the treatment of substance use disorder. It's basically a counseling app. Very interesting company doing some very interesting things. I encourage you to check out their website. And it's pear, just like the fruit. So what I'm going to do this afternoon, we're going to have a little bit more of an interactive session here. And don't worry, I'm not going to make you get up and dance around or anything crazy, unless you want to. No, anybody? But we're going to have some cases, some discussions about things that aren't easy to talk about. And the focus of the presentation is how do we intervene in folks that have substance use disorders in an optimal fashion. As a healthcare provider, as somebody who's ancillary to a healthcare provider, these can be very difficult and challenging conversations to have. And over the years, I've collected some of the stories that I've heard, some of the ways, the creative ways in which folks have built relationships with clinics in order to better serve their patients, and I'll share with you all of that as well. As was mentioned, I am also in long-term recovery. I am 7.5 years from my sobriety date. I started really in pharmacy school with using Ritalin and Adderall to help me study, which they don't do that anymore, right? We know what happens. I'll give you an interesting snippet on stimulant abuse and how prevalent it is. But it started there for me. It escalated to opiates. And then basically over the next 15 years, I laid down this path of destruction that would cost me my marriage, my finances leading to bankruptcy, my professional career at the time. And then I went into treatment. You can recover from this, and I've been blessed to be able to find a home working in this field. I have met some of the most caring, selfless, amazing individuals that work in addiction medicine. There's truly a lot of great people out there. Unfortunately, there's some other people as well that are in it and have profit motives for money, and people have read those stories, things that go on in Florida and other places that have large concentrations of addiction treatment centers and so forth. But I absolutely love working in this field. I could not imagine doing anything else, truly. So what we'll do is we'll go quickly through the trends in non-medical opioid use. I'm sure you've already seen this. Everybody's familiar with the scope of the epidemic, unless you've been basically living under a rock on a desert island somewhere on another planet. Lists substance use disorder resources that clinicians can provide to patients and families. There are some very simple, what I call leave-behinds, or pamphlets, little booklets, things that you can print out that you can give to friends or family members that will go through issues related to substance use disorders, different types of drug abuse and so forth. Things I find very, very valuable, written at a level that anybody can read that doesn't have to be a healthcare professional. And then, most importantly, using effective methods to intervene in the treatment of patients with substance use disorders. I'll speak for my own profession. We have a very difficult time with this. Pharmacists are very judgmental in many places. And I've seen this literally from coast to coast. There's a lot of judgment sometimes, the stigma around addiction, the way patients are treated, the way that they interact with clinicians that work in addiction treatment centers. And I think a lot of that is really due to lack of education, but it's also this kind of environmental thing that we grew up as pharmacists with. And I'll give you an example. I grew up working in a small town community pharmacy, and we had a nice computer entry system for the prescriptions. And you could type in free text comments about patients. And it's not uncommon to go into that system and see, watch out for this junkie, or triple count this scumbag's pills, or this person's going to screw you over, things like that. So there's this, again, I'm not sure where it comes from, but it's really generational. I'm seeing a lot of that go away as younger folks come up and enter the profession, and I hope that that does go away, because these are sick individuals. They have a chronic disease, and they should be treated just like we treat all of our patients, with respect. So approximately 115 Americans die every day from an opioid overdose. So that's basically crashing a small plane on a daily basis. That's about 5 people an hour. Okay, just put that in perspective. So in the hour that I talk, 5 of you in this room, if we all had opioid problems, would overdose and die. All we hear about is fentanyl. How prevalent is fentanyl? Well, this is earlier data. We don't have current data yet, but 20% is going to be on the low end next time that number is published. Okay, I believe that was 2016, if I remember correctly. It's probably going to be closer to 50, 60%. Fentanyl is in everything. Everything. They put it in, and people say that this doesn't happen with marijuana. Yes, they do. They lace marijuana with fentanyl. There's been plenty of cases of it. They lace heroin with fentanyl to give an additional kind of potency to the high. You know how anybody that knows fentanyl knows it's a tiny, tiny amount that we use. We measure it in micrograms to get a clinical effect. So it doesn't take that much to tip somebody over the edge. But fentanyl is a big part of it. And where is this coming from? Where's fentanyl coming from? Is this coming from people somehow sucking it out of fentanyl patches, or where is this coming from? Yeah, it's China. China's the biggest exporter of chemicals in the world, including drugs. And their export rules coming out of the country are very lax, very, very lax. It's very easy for people to get fentanyl. And the cartels have capitalized on this. Again, the very cheap cost of it, put a little bit extra thinking I get an added potency, an added edge to my product, and people overdose and die. It is now the most common cause of accidental death. In the 7+ years I've been working in this field, the statistic that hit me the hardest, it really put this, and I hear them every once in a while now, these statistics that put things in perspective, like I said, crashing a jet once a day, was that I remember when drug overdose deaths eclipsed car accidents as the #1 cause of accidental death. People remember that? Wasn't that long ago. It now eclipses gun violence as the #1 cause of death. And it's not getting any better. We have a very, very, very long way to go. We've made some great strides. We have some good medications, not great. We have good medications, we have good treatment, but we still have a long way to go. The other interesting statistic I saw, was that for the first time in almost 6 decades, we saw a decrease in life expectancy. And statisticians directly pointed to the opioid epidemic as the reason why we saw that. It costs this country over $78 billion annually. What are these costs attributed to? What makes up that number? Law enforcement, treatment, what else? Lost productivity, incarceration, yes, all of those. So again, this just shows you the age-adjusted rate of drug overdose deaths. It was 3 times the rate in 1999. That wasn't that long ago. That number is very scary. And you see the trend there for everybody, and then even broken down males and females. It's a little bit more pronounced for males than it is for females, but nevertheless, the rates are continuing to go up. So according to results from the 2014 National Survey on Drug Use and Health, an estimated 2.1 million Americans use prescription drugs non-medically for the first time within the past year. This averages to about 5,750 initiates per day. This is including kids. Okay, a lot of this data comes from high school kids. Okay, that's pretty good. Almost 6,000 people a day try drugs for the first time. That's crazy. The NIDA, the National Institute on Drug Abuse's Monitoring the Future Survey of Substance Use and Attitudes in Teens found that about 1 in 13 high school seniors reported past year non-medical use of the prescription stimulant Adderall. Adderall, if you don't know, is amphetamine. In 2015, and nearly 1 in 23 reported misusing the opioid pain reliever Vicodin. This blows my mind. I like to think I graduated high school not that long ago, even though it was 1994. And I hung around, obviously, with the crew that liked to do drugs. This stuff was not existent. There were never any pills, there were never any powders, any of that stuff. It was marijuana, alcohol, and then maybe once or twice a year things like LSD or mushrooms would float through. And we do that. But never was anybody passing out pills. Never. It never crossed our mind to do that. And thank God it didn't, because I guarantee you I would have been one of those individuals who partook in that. People don't start using heroin as a primary drug of choice. At least 80% of folks in this country that end up using heroin previously took opioid pain relievers for non-medical reasons, according to a 2013 survey from SAMHSA. So most of the folks are not like me. I was an experimenter. I did not have a prescription for a legitimate medical use. I was abusing stimulants to help me study. My brain is wired a certain way to enjoy stimulants more than 90% of this room do in this room. I feel very, very different when I use a stimulant or I take an opiate. And that feeling, that high, whatever you want to call it, there are no words that I can give you that would do it justice. The only thing I've ever heard that comes close, somebody said, is I was looking into the face of God. It's a feeling that you didn't think was possible to feel. You want to feel that way all the time. You don't want to feel any different. And your body interprets that as almost self-confidence and motivation. So I felt that I couldn't get things done unless I was using drugs. You know, in school it was papers and projects. In my professional career it was all my other responsibilities. As a husband it was managing a relationship. As a friend, managing my friendships, my social groups. I failed miserably at that. Still among folks that are prescribed opioids for pain, the drugs typically do not lead to addiction if people use them as directed. Among people who take prescription opioids as directed for a year, about 5% will develop an addiction disorder, according to the NIH. So 5% is still a lot if you think of the number of prescriptions that go out for opioid pain relievers on a regular basis still. Now, have we made a dent in reducing the number of prescriptions for opioid pain relievers that are being prescribed? We have. We actually have. We haven't seen that translate yet into a decrease in overdose deaths. And it may take a little while and a little bit more decrease for that to actually show up. I put this up to put your state in perspective. So you guys are right there with me in Massachusetts. We are statistically higher than the US rate in terms of overdose death rates. So we have one of the largest scopes of the problem here, all the way down here. This area is probably the most brutal West Virginia, Kentucky, Tennessee, Appalachia. It's been part of my territory for a long time. I have a lot of clinicians there that are now friends. The scope of the epidemic down there is indescribable. You see it everywhere. You see it on the side of the road. You see people sitting and using, in a McDonald's parking lot, which you could see around here too, but it's so commonplace. If you ever see specials on TV, any of the HBO documentaries or any of these other documentaries, or even if you've read the book Dreamland by Sam Quinones, that's Ohio. So that whole area has a lot of history to it. I forget the exact statistic, but a lot of it in West Virginia was due to, you have the whole coal mining industry there, and guys getting injured all the time, and they would continuously prescribe more and more and more opiates. And I forget, at one point there was like enough opiate in the town to give every citizen, I think, 3 bottles of Vicodin. It was something crazy like that. So I'm going to take a minute here, and you can either just think about this, talk to people at your table, but let's answer a couple of questions. So where would one go to find resources appropriate for patients and their families struggling with substance use disorder? If you know, what are those resources you might recommend? And how would you offer these resources to a patient? You probably don't want to go, hey man, it looks like you got an issue. You want to take one of these? That's probably not going to go over well. Where would you go to find resources appropriate for patients and their families struggling with SUDs? Where could you go? Anybody? Google. Why not? Everybody Googles everything these days, right? It'll lead you to a place that hopefully you'll find something that could be usable for a patient. Absolutely. Where else?
County drug and alcohol website.
County drug and alcohol websites, one of the best resources if they have one. They usually post a lot of great material, a lot of announcements, news, obviously depending on the place. They can be extremely valuable. Where else? AA, meaning you can go to AA meetings, you can go to their website, right, and get information. NA, and what else? Don't forget Al-Anon for families, right? Very important. Anywhere else? Other people in recovery? Yes. Ask other people in recovery what's good. That may help you avoid that awkward exchange when you're trying to present this to somebody. How would you present this? How should I offer this to somebody? Ask somebody in recovery. That's great. Any more? All right, so specifically, what resources would you recommend? So in a very general fashion, you have a patient that you think is struggling with a substance use disorder. They demonstrate signs or symptoms, okay, or even a friend for that matter. What would be appropriate to recommend to them? You know what, let me step back and let's answer another question first. How would you approach that patient? How would you start that conversation? It's not easy. So number one, utilization of the prescription drug monitoring program. I'm hoping that every clinician that has access to it is utilizing it. I got a great quick story because, and I always tell this, because the uptake in the use of PDMPs by addiction docs treating substance use disorders is dismal. It's dismal across the country. And it blows my mind because you have 2 objective things that you can help monitor this disease with. One is a urine drug screen. The second is the PDMP. You got anything else that's objective? Not really, right? So I had this doc in this state who has a very large group of clinics. And my first question when I go in and I meet a new doc or a new clinic or new clinician is, tell me what your intake looks like. Tell me what your patient encounter looks like. How does that go? I'm a new patient, I come in to see you, what happens? He says, all right, well, we do the intake, so they get this thick set of papers, they do a full intake with all the medical history and all the relevant information. Then we go through, we do a urine drug screen, we start them on Suboxone or another buprenorphine product, and then they come back in a week. Okay. There was 2 questions I have in there, because this is, again, a very common interaction. Number 1, did you check the prescription drug monitoring program? No, I don't use it. I don't need to. Really? I know when my patients are lying. How long have you been doing this? 25 years. Okay. You know when your patients are lying. All right, he's a Jedi Knight. You know, he can mind control. So I said, humor me. You have access to it, right? He says, yes, I do. I said, I want you to think of your 5 best, most well-behaved patients. Okay? They've been with you for a long time. You would be absolutely positive that they're not getting any other controlled substances from any other clinician anywhere. And just humor me and run them through, please. 2 of them that had been with them well over 10 years were continuously getting oxycodone, one from a dentist, one from a family medicine doctor. Just goes to show you, you trust the person, you don't trust the disease. That's the disease at its finest right there, the deception that goes along with it. It is an invaluable, underutilized tool. The other thing, and I think you could hear most of it, but there were 2 words or 2 kind of approaches here that are important. She said, I'm required to look at the prescription drug monitoring program. That takes the kind of responsibility off of you in terms of you're trying to punish them or you're trying to catch them, you're trying to get them. I'm required to do this. It could be a requirement that you have in your pharmacy. It could be a state law. It could be just your own person. I'm required. I require myself. But you're requiring to go through. And I see that you've gotten prescriptions from other docs. Help me understand this, right? Not what are you doing? What's wrong with you? You know, that's not going to go over well, right? But help me understand this, okay? So those open-ended questions, okay? And we'll get into motivational interviewing, and I'll show you a couple of slides on that, and how very powerful that can be. Very simple, very, very powerful. Use it as a teaching moment, okay? And when you do that, and that theme is going to be throughout a lot of these interactions, it melts away that kind of police mentality that they think you're out to get them. I'm working with you. I want to do everything possible to help you battle this disease. This is one tool that I have. Let's take a look at it. Very good. Anybody else? All right. And then the last part of it was what specific resources? Does anybody know specific places you can go or what you could give them in terms of materials? It's kind of a tough question. It's very abstract. All right, so somebody mentioned AA. When you go on AA's website or NA's website, you can put in a zip code and a radius, and it'll give you all the meetings in that area, within that radius, and it'll tell you what kind of a meeting it is. Open meeting means anybody can go. Closed means it's only for a certain group of folks, men's, women's, and there's all sorts of different types, okay? Could you leave that on your counter in a pharmacy, or have that somewhere in your clinic? That somebody could just pick them up? You don't have to say, hey dude, you need to take one of those. You're not looking too good, right? Leave them there. Put them in a little thing that says, you know, list of local AA meetings. Simple things like that. I'll show you, actually I think it just goes into it on the next slide. Yeah, these are my favorite websites. If you don't utilize these websites, if you're going to use substance use disorder materials, use these websites. NIH, which is drugabuse.gov, that's NIDA specifically. They have these great things called drug fact series, which are about specific types of substance use disorders and what, you know, abuse of certain drugs can do to the body. Very, very easy to read, very valuable whether you're a clinician or a patient, doesn't matter. SAMHSA. SAMHSA is the division of the federal government that really focuses on treatment, the Substance Abuse and Mental Health Services Administration. This stuff I find more valuable for clinicians. This is more for us. It's a little more technical, it's a little more data heavy, if you will. Talks about results of clinical trials sometimes. But there are some things on there that patients may find very, very useful. Similar things you'd find on the NIDA website. You can print them out. They're one-pagers basically. Again, you could leave those on a counter, okay? You put them in a discharge folder. You know, whatever you may do, something benign like that, so you're not generating potential conflict. Or you may want to face it head on. As your clinician, I'm concerned that you may have a substance use disorder. These are the reasons why, and see how that conversation goes. 9 out of 10 times it's going to end up in conflict, but it depends on what your approach is, okay? And how acute the situation is as well. So we talked about the AA, NA, and Al-Anon meetings. This Learn to Cope group hasn't permeated Pennsylvania yet, but that's a parent support group that started in New England, and they've spread a few areas of the country. It was a mother who had a son that was going through this, couldn't find anybody to talk to that felt they understood what she was going through, so she formed this group, and it's become this huge nonprofit organization. You can leave a list of treatment facilities. Find out what the local treatment facilities are in the area and type up a list. And you can separate them. Detox, residential treatment, outpatient. You can even put Suboxone clinic because people will know what that means. Okay, I'm not a big fan of using brand names and saying they're Suboxone clinics because the medication is only part of the treatment. Makes it sound like the medication is all the treatment. It's not. It's a part of it. And the list of buprenorphine providers. So on the SAMHSA website, this is they have a buprenorphine finder, and they also have an inpatient treatment locator, and you can do the same thing with the zip code, as I mentioned before, okay? You may want to do this for your own benefit, just to know what clinics are in your area, okay? Just so you can, if there's a potential opportunity to collaborate, that may help in the, facilitate the treatment of patients as well. If you want to get really clinical, there's this thing called the SBIRT, which I'm sure a lot of you have heard of, the Screening, Brief Intervention, and Referral to Treatment. It's a very quick, easy to do questionnaire that suggests there may be a substance use disorder, and it refers somebody to a specific type of treatment, okay? There's a lot of research going on using these in pharmacies. I'm a little mixed on that personally. I'm not sure if that's our role. Can't figure it out yet, but let's see how the data comes out when we publish some of these studies. But it's been shown to be extremely effective in addressing or finding substance use disorders very early on. A lot of primary care facilities, family medicine will use these. They do them in my son's junior high school, or the one he will go to, which I went to an opioid task force meeting. I was thrilled to hear that they're starting to do SBIRT screenings in junior high school. That's great. And you guys are the best resource. Your knowledge, your understanding of medicine, medications, treatment, you're going to be the best resource, especially if you have that relationship with somebody. I don't care what type of a clinician you are. If you've built that trust with somebody over years, whether that's coming to the office to see you for their annual appointment or physical, or them stopping in the pharmacy once a month to pick up their medication, you see them, you've built trust with them. You know where you can go, you know what you need to do to kind of get to that patient in many cases without it becoming a conflict. All right, so let's do another one real quick. We'll take just a couple of minutes. So what issues do you anticipate facing when providing info to patients and their caregivers? And what methods can you utilize to overcome these challenges? What issues are you going to face? You will face, not anticipate. Trust me, you will face. Denial. Yeah, denial. Keep going with that. What else? Hostility. Hostility. Absolutely. Anything else? I think we get the picture. Insurance non-coverage. Yes, we're going to deal with that in this field very much as well, unfortunately. So how do you overcome that? Because 9 out of 10 times, if not 10 out of 10, it's going to go exactly how we just described it. Okay? There's no other, and that's also part of the disease. That person is sick. That's a response. It's a protective mechanism for them with their addiction. Okay? It is to be kind of hostile back. All right? I'm not saying it excuses the behavior in any way, but just keep that in mind. So what can you do? Say, oh, I tried. Good luck to you. Yeah. Hang in there and build a relationship. One of the most common questions I get is, what do I do if a friend or a peer I think has an issue and I want to approach them and they don't want anything to do with it? I say, keep bothering them. Don't be confrontational. Just start planting little seeds, little breadcrumbs here and there. Look, I don't know what's going on. I'm not going to guess, but something is off. You're not who you usually are here. If you want to talk, if I can help you in any way, you know where to find me. I'm here. And anytime you see them in that maybe inebriated state or anything, you say the same thing. Look, what's going on? Are you okay? And they may say, F you, and walk away. It's going to happen, right? But maybe the 6th or 7th time they say, you know what? Yeah, I do have a problem. Where do I go? And that's exactly how it happens. Anything else? So really just hanging in there. I think we already talked about our choice of language is very important. I hate to say it, but think before you speak. It's very easy in a heated conversation to just blurt, just keep it going, and that's not going to get either of you anywhere. Patient's going to leave. You're going to be stewing for the rest of your time while you're at work, and then probably when you go home about it, it's not worth it. It's not worth it for your own mental health. But again, the bottom line is these are patients. So we have a duty to help them in whatever way we can. You got to read these. These are special. I have collected these from pharmacists over the years that I've encountered. As I mentioned, we have an issue with judgment in our profession. The one I commonly hear is, well, I don't like the Suboxone stuff. You're just substituting one habit for another. Say, okay. Does that habit make them go out and steal things and engage in risky behaviors and share needles and stuff? Because I don't think it does. Very different. The stock question, or the stock answer. I don't stock these products because somebody actually said this. I don't stock those products because I don't believe this is a disease and it should be treated. That one didn't go over so well. I'm usually very even-keeled. That one didn't go over too well. And that guy wouldn't budge. We don't have any in stock, and I don't think we'll be getting any more. We do this all the time with controlled substances as pharmacists, right? Quickest and easiest way out. Because the wholesalers are now controlling the amount, you can throw that one in there. Well, I've gotten my quota for the month. I can't order anymore. There's nothing I can do about it. We don't like dealing with those folks. We don't carry this stuff. How long are they going to be on this stuff? Pharmacists got to know, how long are you going to be? What's the tapering plan? That one cracks me up. Pharmacists calling the doc, what's the tapering plan, doc? The tapering plan? Why would you taper somebody off of this necessarily? There are people that can get off it. The bottom line is with those medications, it doesn't matter if it's Vivitrol, Methadone, or Suboxone. We have no idea how long the optimal treatment duration is. And studies tell us every time we start to take people off, the rates of relapse are astronomical. So the best we know now, treat people for at least a year, if not 2 or 3 at minimum, and then taper off. We aren't taking any more buprenorphine patients. A pharmacist said that. I didn't know we had a limit like the docs do. I was unaware of that. All right, I'm going to let you these are for your reference, but there have actually been a validated set of behaviors that are more likely to suggest addictive behavior. So if you're trying to tease out what's going on with this patient and you're concerned about an addictive disorder, let me just run through some of the ones that are more suggestive. Obviously, selling, forging scripts. That's what I did. I ended up with 513 felony counts related to writing fake prescriptions. I guess the DEA frowns on that. I was unaware. Injecting, snorting oral formulations. I actually had a doc tell me once, I know my patient snorts their Suboxone, but if that's the way they take it, that's the way they take it. Another special individual. Obtaining prescription drugs from non-medical sources, concurrent abuse of alcohol or illicit drugs. That one's tough because a lot of people that are in treatment for opioid dependence also test positive for marijuana, and they continue to. And with medicalization and legalization of it, this is a big conundrum for folks working in the field. What do I do with those patients? Do I toss them out? Do I try to get them to taper off of it? Or do I just leave it alone? Okay? It's tough. Multiple dose escalations. When the patient starts dosing themselves, regardless of what you as a clinician have told them to do, that's a red flag. And I brought this one up intentionally because a lot of patients will get their Suboxone prescriptions and they say, I take it when I need it. That's not the way you take that medication. It's a chronic medication. You take it at the same time every day like you would take your blood pressure or your diabetes medication. okay? If you're still self-medicating if you're doing that. You take it when you need it, or I take a little piece when I need it, you know? It's not good. Prescription loss. Great story. There was, I go to this American Pharmacists Association meeting every year in Utah in May and June. And it's an educational forum. There's a lot of pharmacy students that go, but there's a lot of pharmacists and faculty members that go as well. And there's this well-known pain and addiction doc in Cleveland who always gives this lecture about pain and addiction and the crossover. And he says, all right, I got a lot of pharmacy students in this room, and I'm going to tell you guys something you don't know. You think you know it, but you don't. And he says, what is the most hydrophilic class of drugs? Meaning water-liking, okay? And you know, the kids go, wow, that's this one, metoprolol, you know, throwing out all sorts of things. He says, no, it's opioids. He says, what other class of drugs is more attracted to the toilet or the sink than opioids? Repeatedly seeking prescriptions from other clinicians or emergency rooms, that's where the PDMP can help. Evidence in deterioration in the ability to function at work, family, social. This was a big one for me. I would withdraw, I would disappear for weeks at a time. And people would notice. You know, when I was in school, I might be able to get away with it. When I had adult responsibilities and real jobs, I couldn't. People notice. A lot more people are affected. That's a big one when we work in the healthcare professions that you see when you have a healthcare provider struggling. And repeated resistance to changes in therapy despite clear evidence of adverse physical or psychological effects from the drug. You know, an example would be you have a patient who's been chronically taking OxyContin for chronic pain, and they develop this horrible, horrible constipation. You say, well, I want to switch you to another opiate, maybe that won't. No, I'm not switching, no way, no way. Doesn't mean they're doing something with it or abusing it. It's just you put it in context with some other things that may be going on to help you try and decipher, is this patient trying to pull one over on me, or is this just an issue that they're concerned about? And the rest of these are less suggestive. I'm not going to run through each and every one of them, but there can be reasons why people are doing certain things with drugs, and we have to dig into that and find out why. You know, why do you keep your opiates when you're done with them? You get a prescription for 20 Percocet, right? You take 2 or 3, let's say for a dental procedure. You take 2 or 3 like the normal person does, and what do? They put them in their medicine cabinet. And I always ask, why do you put them back in your medicine cabinet? Well, because they worked. When I had pain, it took it away, and it also helped me sleep really good, right? That's not a sign of an addictive disease. That's what they're perceiving. I'm going to keep this because it took the pain away and it made me sleep really good, and if that happens again, I got something ready to go. Lose the judgment. Don't think of these patients as different. They're not. They have a chronic disease. Treat them just the same as you would as anybody else that comes to your pharmacy. Showing concern, providing support. We talked about the list of 12-step meetings. List of addiction docs, therapists, treatment centers in the area. Therapists especially. Educational information about addiction. So all the things we talked about through SAMHSA and NIDA. Something that can go a very long way, which is a very simple intervention, is changing the language we use. Okay, these are terms that we try to avoid these days. And I'll tell you, as somebody in recovery, there are some of these that I still use. You know, I go to an NA meeting, I say, hi, I'm Jake and I'm an addict. We still use that in the halls, okay? Or I probably said at the beginning, I've been clean for 7.5 years. We still say that, even though we shouldn't be saying that. So instead of an addict, abuser, a junkie, or a user, person with a substance use disorder. Clean or dirty, we refer to a urine drug screen. They had a dirty urine drug screen. That just sounds disgusting, right? How do you think a patient, I'll never forget, I was sitting in a waiting room once, and I could hear, the door must have been paper thin. And I heard from the back, she just threw a dirty urine. Well, get out of the way then. You know? And the patient, it was the only patient in the waiting room. You know, how do you think she felt? A habit or a drug habit. And then we don't use this term opioid replacement therapy, ORT, and I'm laughing because, as I mentioned, I work for like a tech company that has a counseling app, and they had no experience in addiction medicine. And the first thing I had to do was go through all the literature and take out the term opioid replacement therapy and put in medication-assisted treatment. Sounds like you're replacing one habit for another. And as I mentioned, from a clinical data standpoint, that is certainly not the case, okay? Motivational interviewing. So these are techniques that you can use, and we've kind of gone through this with some examples. It focuses on exploring and resolving ambivalence and centers on motivational processes within the individual that facilitate change. It differs from more type of coercive approaches or externally driven methods for motivating change. It doesn't impose change that may be inconsistent with the person's own values, beliefs, or wishes, but rather supports in a manner congruent with the person's own values and concerns. And I'll break that down in English in just a second. Motivational interviewing is a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. So this is some great examples of things that you can remember that qualify as motivational interviewing. The other interesting part of this is when we talk about medications like buprenorphine or methadone or Vivitrol, which is naltrexone, those are approved by the FDA in combination with psychosocial support, okay, which means you should be seeing a counselor or receiving some other psychosocial support. This is considered psychosocial support. So you may not have access to a counselor or a therapist. You can use this as a clinician on your own, and it works. So DARN, desire, ability, reasons, and need. What do you like, wish, or hope for? What is possible? What can you or could you do? What are you able to do? Why would you make this change? What would be some specific benefits? And how important is this? So it sounds a little touchy-feely type stuff, and you're not going to sit there and say, what do you like? What do you wish? That's not what you use the questions and the interviewing in context. You know, you bring up a discussion about their children. So, well, I lost my daughter to child services. Well, maybe if you get better, you can get her back. You know, that's another reason, another great motivator to get into recovery. Open-ended questions. Again, we've gone through this. Clients should do most of the talking, not you, okay? With these folks, it can be very difficult sometimes to elicit that response and to get the conversation going. But ideally, it's the patient that's doing the talking. You use affirmation, reflective listening, and then summarize at the end. And the goal is to elicit what we call change talk. So here's a good example that we've actually already given. Your patient record shows you've been getting this prescription too infrequently. I can't fill this. End of conversation. The state's PDMP requires or encourages me to check how frequently you receive this medication. Can you help me understand why you're getting so much from many different doctors? I'm not even sure I'd use the second half. I would probably use something like I said before. Can you help me understand and decipher all these different medications here and what they're for? It's a little more benign. Build relationships. If you're working in a community where you're serving patients with substance use disorders, get to know the providers that are treating them. I say this especially with pharmacists. Go over and introduce yourself. Ask how you can help collaborate with the care of their patients. Ask how you can help them make their job easier. What do you want me to report back to you? How do you want me to manage your patients? You know, what are your red flags that I should be getting back to you on? Trust me, they will eat it up, okay? I've seen clinics and docs do this and establish incredible relationships, which in the end truly benefited the patient. Know the treatment providers in your area. Obviously, the empathy is a big part of this. PDMPs, and then what I always say to pharmacists is know what you're talking about before you pick up that phone and ask them, when are we going to taper this person off of their Suboxone? Because you're going to have a clinical conversation. You better know what you're talking about. So why aren't we doing more drug testing earlier on in life, basically in school ages, junior high, high school? And you mentioned you had some parents that I wish I would have known earlier. Unfortunately, you have more parents that say, that's not my kid. Okay, we got what we call the NIMBY attitude, not in my backyard. All right, this isn't don't put an addiction clinic in our city. No way. We don't have that problem here. And that's truthfully what happens. They start to, I've seen it tried, and what happens is people threaten to litigate, and they drop it. They've tried this a lot in schools, especially in pharmacy schools. And once the lawyers get involved, it's a dead issue. Every contract I've ever had for every job I've ever had said that I could be randomly drug tested at any time. How many times in the 15 years I was using do you think I was randomly drug tested? Zero. Zero. I mean, you have to, as we say, we got to meet them where they're at, whether we're talking about the person who's struggling with this or their family. You got to get to them one way or another. And I'm starting to see, in the short time I've been working in this field, I've started to see a lot more acceptance on the school level. Like in my town, I live in Natick, which is just outside of Boston. And it was always a NIMBY town. That's not happening here until we had a few overdoses. And now every week I'm getting the newsletter, the school newsletter, that says they're having another speaker coming on addiction. You know, it was a very big culture change for our town. And I'm seeing a lot more of that, thank God. And parents come out. You know, they'll get somebody like Chris Herron, who was a NBA basketball player from Fall River in Massachusetts. He comes and tells his pretty cool story, so. Yes?
What's your take on educating people that don't accept this as a disease?
Yeah, what's my take on educating people who don't accept this as a disease? If you don't believe this is a disease, that is completely your opinion. Just meet me out in the parking lot after, we'll discuss it in a very brief conversation. That's what I would have done 15 years ago. It's very tough. I have encountered some very hard personalities that said, no, this is not a disease, this is a choice. There are certain people you're not going to convince. And I can show them all the science I want, I can explain all that it is, and that person is not going to accept it. What I've also noticed is that 100% of the time, because I'll dig into why they're so resistant, it's reflection. Usually they had a parent or a sibling or a relative that's either passed away or struggled with a substance use disorder, and that's where their hatred of the whole thing comes from. So it's usually reflection. And it's, again, hard to deal, you can't dig into that, you know. Are you acting like this because your mother was a drug addict? You're not going to ask that question. But you have to keep that in mind. That helps me a little bit. You know, you can imagine me standing in a room and I've had this conversation, not argument, with somebody who said, no, this is why it's not a disease. And I just, at one point in my mind, I'll just say, okay, they're not going to get it. You know, they don't want to educate themselves, that's fine. That's nothing I can do about that. So, very tough one.